talk because those of you who are my students already know me. The rest of you might have the unfortunate ability to get to know me. We're going to let the SOAR president take over and do some introductions because we have a really special speaker today. So Brian, go ahead.
So we're lucky to have Jeff Stone. He is a Humboldt native, and he is a professor of psychology and psychiatry at the University of Arizona. He got his bachelor's from San Jose State University and his PhD from UC Santa Cruz. He has been he has been a co-editor and associate editor on 5 journals, including a special issue of Group Processes and Intergroup Relations and the Journal of Experimental Social Psychology. He has written 15 book chapters and has over 40 publications. Most of his work centers around processes of attitude and behavior change, and he examines underlying prejudice and stereotypes and the reduction of intergroup bias. His currently funded research examines how intergroup bias may contribute directly to ethnic and racial disparities in healthcare. And today he'll be presenting his current work on implicit bias in healthcare. So without further ado, let's welcome Jeff Stone.
I sometimes do need a mic, even though I'll probably get too loud for it. Wow, what a turnout for a Wednesday at 5. Thank you so much for being here today. How many people are here from Humboldt County? Yeah. Eureka High School graduate, grew up on Humboldt Hill, and even though I was admitted to Humboldt State but never attended, I spent so much of my youth on this campus. I'm also a musician. I played some of the biggest gigs of my young life at band, music, theater here. Most of the concerts, my very first concert was Journey in the old basketball stadium here. So for me, this is really an incredible homecoming. First opportunity to give an academic talk on campus. So I'm extremely thrilled to be here. I'm going to tell you about this research that I've been doing now for about 8 years on implicit bias in patient care. And to get you kind of oriented to the kinds of things we're interested in, I'm going to tell a couple of stories to start off with. This is a story that was in the LA Times. When Althea Alexander broke her arm, the attending resident of Los Angeles County USC Medical Center told her, "Hold your arm like you usually hold your can of beer on a Saturday night." Alexander, who's African American, exploded. "What are you talking about?" she demanded. "Do you think I'm a welfare mother?" The white resident shrugged and said, "Well, aren't you?" "Well, no, actually, Alexander was a top official at the USC School of Medicine where the resident was studying." This is Althea right here with the president of the School of Medicine at USC. So there's a couple of things happening here, right? You have a patient responding to a comment from a resident. And one of the things we're interested in is how much is what's happening here conscious and deliberate? How much is the resident expressing something that he really, intends to say? Or how much of this could be more of an automatic response, something that happens without much thought, right? But it's a response to issues of race, ethnicity, religion, gender, so forth. Let me show you another example that gets, I think, a little closer to the kinds of things we're studying. This is in a really great book on how doctors think by Jerome Groopman. Story relayed by Dr. Karen Delgado. She talks about how a young man was brought into the ER in the hospital in the wee hours. The police had found him sleeping in the steps of a local art museum. He was unshaven and his clothes dirty, and he was uncooperative, unwilling to rouse himself and respond with any clarity to the triage nurse's questions. Dr. Delgado was busy that night attending to other patients, so she eyeballed him and decided that he could stay on the gurney in the corridor, another homeless hippie who would be given breakfast in the morning and return to the streets. Some hours later, she felt a nurse tugging on her sleeve. "I really want you to go back and examine that guy," the nurse said. Delgado was reluctant, but she had learned to respect a ER nurse who felt something was really wrong with the patient. This is Delgado talking. She says his blood sugar was sky high. The young man was on the brink of a diabetic coma. He'd fallen asleep near the art museum because he was weak and lethargic and unable to make it back to his apartment. It turned out that he was not a vagrant, but a student. And his difficulties giving the police and the triage nurse information reflected the metabolic changes that typify out-of-control diabetes. Now this is an interesting example where you have somebody who's very busy, working very hard, seeing a lot of people, has to make a very quick judgment about somebody, what to do with them, right? She looked at the way he was physically appeared and made a decision about what kind of group he belonged to, and based on that information, made a treatment decision. That almost killed him. Is that on purpose? I don't think so. I don't think so. I'm going to try to make a case today that what can happen in these kinds of situations is essentially what we call an automatic or implicit bias. It kind of creeps into the way people make judgments. As you'll see in a little bit, it creeps into the way people interact, and it can cause these kinds of disparities in health outcomes for people. Now, in psychology, we know a lot about how this works, right? And this is, your standard bias kind of model. We know that it all begins with the way that we naturally categorize information in our social environment. We're really good that when we come into something completely new for the first time, we can look at its attributes and say, that looks to me like a chair. That's beautiful, because to the degree I have information about what chairs are like, I know what to do with this object, right? I know I can put my arm up or my leg on it while I lecture, right? I can sit down when I get tired. Well, we do the same thing with people, right? The minute we come across somebody we've never met, we look at their physical characteristics and we decide, aha, you belong to this group. And to the degree we have information about what that group is like, it greases the wheels for interaction. That's right. It's one reason why stereotypes are so hard to get a hold of. And that's the next step in the process, right? The minute we categorize somebody as a member of a group, we activate the beliefs about what the group is like. Those are our stereotypes. And most stereotypes come along two dimensions. They describe the group from warm to cold and from competent to incompetent, right? Now, stereotypes by themselves can lead us to discriminate, to act based on that information. Stereotypes can be, when they're negative, can lead to negative acts that are passive or active, that can lead to help or harm. Positive stereotypes tend to lead to help, right? It's also the case that our stereotypes can then induce an emotional response. And those are typically what we think of as prejudices, right? And we have a number of different ways that we can be prejudiced. Of course, these two cognitions, if you will, or responses, can work together to drive discrimination, but they can work independently of each other. And it's always very interesting as a psychologist when that happens, right? Because it sets the stage, interestingly, especially for the talk I'm going to give, that you can have people that are very low in prejudice towards a group, but they still hold negative stereotypes, and they can still discriminate. Now, as I kind of preface, we know this can occur consciously and deliberately. People can have their beliefs, and they can consciously decide, I don't like that group because of the way they are, so I'm not going to give somebody a job. I'm not even going to interview them, right? But what we've been interested in social psychology now, for probably going on a decade, maybe two, is the possibility that this can occur spontaneously, automatically, what we refer to as implicitly. Controversial to say non-consciously, but we'll leave that possibility open. But happening so quickly that people aren't controlling it, and it's just kind of happening. Like Dr. Delgado eyeballing this college student who was deciding he was a homeless hippie. Okay. So here's what we've been up to for a while now. In trying to study implicit bias that's happening in patient care, we've been interested first and foremost, do providers, and we're talking doctors, nurses, staff, faculty in medical schools, do they hold stereotypes about patient groups that come to mind automatically, even potentially outside of conscious awareness, when they come into contact with certain members of a group? Does the implicit bias then impact the way that they interact with the member of the group, patient? And does it affect the kinds of decisions that they might make, the kinds of treatment decisions that they might make, even diagnostic decisions that they might make for patients? And then the third thing is, if the first two are true, we want to do something about it, right? And so what we've been spending quite a bit of time on is, does social psychology know anything about reducing bias? I think we do. I'll make the case that, there's some debate about that right now. But to the degree, anything that we've learned over the last 50 years of research could be useful. This would be a great environment to take it into, I think. And so we've been interested in, is it possible to make implicit bias training part of the medical curriculum? We've been doing that at the University of Arizona. And the other thing, and I won't talk about it, but we've done some work on it, can we involve the patients in this process? It's a really interesting thing to think about. A patient going in to interact with the doctor, saying or doing something that would deactivate the doctor's implicit bias. Is that possible? What would that look like? Confront the doctor? Maybe, maybe not. That's a good question. Okay. Now, time for audience participation. How many of you have taken an implicit associations test? Really good. Still only about half? Maybe a third? All right. Well, how do we even know people have an implicit bias? It's a really good question to ask, right? And the way that we know is that we have some measures that we give people. The one I'm going to introduce you to right now is called the Implicit Associations Test. And it's predicated on the assumption that it can measure the strength of automatic associations between concepts. Automatic associations, if then type of thinking, right? And it measures that through a response competition. Now the idea is that if we're all walking around with concepts associated stored in memory, if I ask you to respond to one of those concepts, or if I activate one of those concepts, you can respond more quickly to the second concept. Okay? All right. That's abstract. Let me make it concrete for you. Here's what I'd like you to do. I'd like you to sit right now so that you can slap on your legs. You might need to put stuff on the floor in order to get comfortable. Yeah, there you go. I can hear it all over. All right. Here's what's going to happen. I'm going to show you some words on the screen, okay? And I'm going to ask you to categorize the words on the screen in one of two categories that will be displayed at the top of the screen, okay? And you're going to respond by slapping your right or your left leg, okay? Now, here's the thing. Be as quick and as accurate as possible. You hear the trade-off? As quick and as accurate as possible. And we'll do multiple blocks here so that you get a sense of this, okay? All right. Here we go. First one's training. All right. A word is going to appear on the screen. If you associate the word with the concept of obese people, slap the right. If you associate the word with the concept of thin people, slap the left. Got it? All right, ready? Begin. Good. Pretty all together. All right, let's do a second block, okay? Now this time, when I show you the word, if you associate the concept, associate with the concept of bad, right? If you associate the word with the concept of good, left. Ready? Begin. Good. Okay. We do our first test block, okay? It's going to get a little bit more challenging. This time when I show you a word, if you associate it with the concept of obese people or bad, it'll be the right. If you associate the word with the concept of thin people or good, it'll be the left. Ready? Begin. Pretty good. Sounded very together. All right, let's do another training trial. This is going to be very similar to what you did a minute ago. This time when you see the word, if you associate it with the concept of thin people, it will be the right. If you associate it with the concept of obese people, it will be the left. Ready? Begin. Okay, good. All right, I think you're ready for another test. Okay, again, a couple things to think about here, right? This time when we show you the word, if you associate with the concept of thin people or bad, right? If you associate the concept with obese people or good, left. Ready? Begin. Don't give up. Very good. It comes out the same way every time. Let me explain why. So according to me, this is a measure of something. Let me explain the logic behind the test. So what the implicit association test has you do is sort of a categorization task, right? And in the first couple of trials, what you were doing was just simply categorizing obese and thin words and good and bad words, okay? And probably felt kind of simple to do that, right? But on that third phase, I had you do what's called simultaneous categorization. And here what I was asking you to do was sort of pair the word, the target word, with two things, right? What we say theoretically is what you were doing on that task was the stereotype congruent pairings. Now, why do we say that? Because the assumption, the theoretical assumption, is that what you're all walking around with stored in memory is an association between thin is good and bad and obese is bad. And so when I ask you to do something where that stored categorization is present in your mind, it's pretty easy to do. And you might have noticed on that trial, you were all together. It felt fluent, it was easy for you to do, and you were all doing it together, right? And then we reverse the trial, and this just takes the handedness out of it, right? On any reaction time task, you've got to control for that. And then I had you do another simultaneous categorization task. This one's stereotype incongruent. And the assumption here is what you're not walking around with stored in memory is an association between thin and bad and obese and good. And so when I ask you to do that pairing, it becomes difficult. And you can probably feel you were slower and struggling with it, and you could probably also hear, so was everybody else, right? Because it's not what we're culturally sort of trained to do. Well, what we do with the IAT, and by the way, we do this on computers, so we collect reaction time data as to how quickly people do this and how many errors they make in doing it. We use some math magic to look at a measure of implicit bias, meaning the slower reaction time on the incongruent trials compared to the congruent trials, created a different score essentially. Such that typically what you see in published studies, and I'll show you examples here in a little bit, higher scores indicate higher implicit bias, meaning you can't do the incongruent trials, right? I do also like to point out, because this question always comes up when I give a talk on this, well, what if you did it in a reverse order? What if you used pictures instead of words? Would it change how I struggled with the incongruent versus congruent? The answer is they've already done a lot of those studies, and it doesn't matter significantly. Varies a little bit, but not to a point where we would really miss a person's implicit bias by much. The other thing, and I'll come back to this in a minute, is there are a number of implicit measures out there that measure implicit attitudes, implicit stereotyping, and there's been a number of comparisons across the different measures, and it turns out the IAT is still the one that actually has the highest validity and reliability. Reliability is good, test retest. If I came back next week, chances are we would kind of hear you all doing the same thing, right? The validity is important because that's really when it comes to being able to predict behavior. The IAT is still the best of them. That may not be saying much. And some of you may know this literature well enough to know that we're wondering about the validity of the test right now, but nonetheless, that's it. Okay, I just have to quickly, if there's any questions. I don't want to take a lot of time because I want to get through the talk. But... Okay, well maybe after the talk we can talk about the IAT a little bit more. Let me just show you how we use it in our research with doctors. So one of the things that we're interested in is their bias towards Hispanic patients. I live in Tucson, Arizona. We're an hour from the Mexican border. The largest minority patient group in our neck of the woods are Hispanic people from Mexico, Central America, Latin America. And so we're very interested in measuring prejudice towards Hispanics. And so we'll have them compare white and Hispanic faces, pleasant and unpleasant words. You can see the compatible and incompatible trials. But we're also interested in their stereotypes that they hold about Hispanic patients, and the one that's been documented quite a bit in literature is that Hispanic patients, this is also true for perceptions of African American and Indian patients, that they're non-adherent with medical advice. They don't follow medical advice, which really is a big deal if you're a doctor, right? If I have a patient, I don't think they're going to do what I'm going to tell them. Why would I tell them anything? They're not going to do it anyway. So if that's coming online automatically, we think that could be a potential big problem for the patients, right? So what we do is we create IATs like this, just to get through some of the nuts and bolts of how we use the data. We create the D-score. We do some corrections that are common in the literature for outlier scores. People going so fast that it doesn't make sense, or going so slow that they're not following the directions, right? Okay. Well, I'm going to just cut to the chase about one major thing, and that is we've done a lot to document implicit bias among health professionals. And we've documented several times now among physicians and also nurses that they hold implicit stereotypes, non-compliance for Hispanic patients. We also have some evidence of implicit prejudice towards Hispanic patients. We've also done some work looking at African American patients. The study with Gordon Moskowitz we did where we used a subliminal priming test. So we got away completely from the fact that when you were doing the IAT, you could see the words, right? And we did this with subliminal primes of black and white faces. So they weren't aware of what they were doing, and we found implicit bias in that manner as well. We're working on one looking at American Indian patients, and then we've got a paper in review right now. There's a lot of interest in implicit bias towards specific diseases. And there's a study by one of my colleagues on implicit bias towards women with lung cancer versus breast cancer. This one we did for women with cervical cancer versus ovarian cancer and found implicit bias. Both we think are caused by the belief that if you have lung cancer, it's probably because you smoked. If you have cervical cancer, it's probably because you had a sexually transmitted disease. In other words, it's a blaming the patient kind of thing, right? And it's kind of cropping up at the implicit level. Okay, so we found lots of evidence, and so have other people, of implicit bias among healthcare professionals, but seriously, you might ask, and we get asked this a lot, so what? Why should anybody care? You can get people to do this on a reaction time task. What does that really mean, right? It's the validity question. What does it mean? And so what we wanted to do to try to tap into that is to look at whether or not when providers interact with Hispanic patients in the clinic, do they communicate the implicit bias in a way that makes the patient say, I don't want to come back and see this doctor. I didn't like this interaction, and I'm not coming back. In other words, patient satisfaction. Now, that's really sort of saying the IAT would predict behavior in a way that somebody else is picking up on it. And this is where we get into the sort of nuts and bolts of the IAT and what's kind of going on right now in our field. A little debate over whether we should even be using this measure for anything, because some studies have been done recently, some big meta-analysis where they combine across studies have shown that the IAT is a very weak predictor of behavior. And what we find interesting about these studies is that most of them are looking at studies done in the lab, right? A very carefully controlled laboratory situation. I think that should be good for this question, right? Because laboratory scenarios tend to cut out all the noise that gets in the way of being able to look at an attitude-behavior relationship. But nonetheless, the press has really sort of jumped on this. Maybe you've seen some of these articles, right? The IAT is a terrible measure. It's really been drugged through the press, and a lot of people's work's been sort of called into question for that. But there's another side to the story that's really interesting that doesn't get much press, so you'll get it now from me. And that is, when you look at the studies that have been done in the healthcare literature on implicit bias, you see these really impressive levels of the IAT predicting behavior. And this is just sort of a list of the ones that I've got right now. And so, it all started with the Green paper in 2007. They found that implicit bias among residents predicted a poor treatment decision for an African American versus a white patient with coronary heart disease. You have it predicting warmth and friendliness, and then that predicting patient satisfaction, predicting a doctor's verbal dominance, patient-centeredness. In other words, the other story that we're finding pretty interesting is that if you go into the clinic to try to measure how implicit bias is affecting patient outcomes, or at least physician or nurse behavior, we see much more moderate, significant correlations. So there's something more to the story. Well, I'll take about the study that we've been doing. And there's something theoretically unique, I think, about what we're doing here as well. So we're very interested in that relationship between physician implicit bias and patient satisfaction. But we're especially interested in what mediates that relationship. And some of the studies I just showed you have done a pretty good job. There's laboratory studies that show this as well. Showing that where implicit bias seems to have its effect mostly on behavior is through nonverbals. So when you interact with somebody, to the degree that you have implicit bias towards them, it kind of makes us non-verbally do this. And there's all kinds of things that come with that, right? There's things like we don't make eye contact, we don't face somebody when we're talking to them. You know, we're all closed up and we're talking over here. We put a lot more distance between somebody, right? All these little things we do that, you know, create sort of the impression that we don't really want to be there. And so, you know, you can find verbal dominance, patient-centeredness, affective tone, and these sort of correlating with how a patient might feel. Well, one of the things that we got interested in is whether or not there are linguistic cues that also reveal the degree of implicit bias. And so that when people communicate to the degree that they have implicit bias, they may change the kinds of words they use. And that also has an effect on how people perceive the person they're interacting with. And so there's some things that come out of the health literature, like physician-patient verbal synchrony, the degree to which they're matching their articles in their language. And my colleague, Matthias Mell, is on this grant with us. He's shown that cancer patients, when they're dealing with going through treatment, they do better with the treatment when they have a matching language style with their significant other or their partner that they're going through the treatment with. Things like that. This demand withdrawal pattern is interesting. It's sort of like the situation where one partner says, we should get more exercise. And the patient says, don't tell me what to do. You can hear, demand withdrawal, right? Well, imagine a doctor. We need to get more exercise, and a patient responding to that. And one possibility is that doctors with implicit bias use more sort of, demands like that that cause withdrawal from a patient. And then there's one that's been in the literature for a long time, linguistic intergroup bias. And basically the finding in that literature is that people that are prejudiced use more abstract language when they talk about outgroups. So we're going to look for the abstraction in the language. And look to see whether or not we could document this side and replicate other studies, but maybe account for variance unexplained through the verbal, this what we're calling implicit verbal bias. So, how do we do that? Well, what we were able to do was recruit residents in family and internal medicine who work in our hospital system. Residents are the grad students of medicine, if you're not sure sort of who they are. They've gone through 4 years of medicine, but they have to do 3 years of residency typically before they can really go out and practice medicine. So these are people that are meeting with patients all the time. To include them, they had to complete all of the pre- and post-clinical steps in our study. They had to do at least 2 reportings with a Hispanic patient. And then afterwards, when we told them that we were measuring their implicit bias and how they communicated, they had to say it was okay for us to use their data. And everybody said that was fine. So we had 53 residents in the study. Now, patients, we had to recruit Hispanic patients. And so the patients that are in this data set I'm going to show you, they had to have an appointment with the enrolled physician, with that enrolled resident. They had to self-identify as Hispanic, either in an intake questionnaire that gets put into the patient record system, or if they requested the meeting with the resident be held in Spanish, we assume that would be a cue to the resident that this person is Hispanic, and that would activate the stereotypes. They had to produce a clear recording, some did not. They had to re-consent as well, only one did not. And we also had 5 people that had extremely low satisfaction ratings, and we tried to figure out, what had happened during that meeting. And what we found is that they either had been sitting in the waiting room, they take you in and they put you in the examination room, and then you have to wait for the doctor. They've been in there for over an hour. So they're going to be happy no matter what happened, right? So we excluded them. There was 9 total, we excluded 5. The others we weren't sure why. So we ended up with 291 patients, which is about 5.5 patients per resident. So we asked them to complete, the residents to complete stereotype IAT, prejudice IAT. We also got an explicit measure of prejudice. What we want to see is explicit prejudice, not just deliberate prejudice, doing something different. Their internal, external motives to not be prejudiced, perspective taking, to what degree do they tend to take the perspective of the person they're interacting with? Lay theories of racism, interesting measure by Rebecca Neal, kind of looks at people's theories of whether you can change prejudice. And it turns out people have their theories about whether you can even change that about somebody. The degree to which they prefer to be colorblind and not recognize differences in race and ethnicity, and the strategies that they have for interaction across racial boundaries, some of which is, I just get the heck out of there as fast as I can, versus I really try to approach and solve the problem, the degree to which people care about those kinds of things. And then we follow them into the clinic, and then what happens during the procedure is, once we consent the patient, we leave a recording device. So we're only looking at audio recordings in this research. We leave that recording device by the sink in the examination room. You think, well, the doctors know it's there, and so they're not going to do their stuff. They forget about it after a while. Maybe the first time, and then after that, they just forget about it. And then we ask the resident afterwards how they thought the meeting went, and we ask the patient their satisfaction ratings. How much do you trust this physician? How much would you recommend this physician to somebody else? Okay? Turns out all that correlates very highly. Okay, data, finally. So we find significant levels of both prejudice and stereotyping of Hispanics among the residents. We also find that those two measures are moderately correlated enough to where we felt like we needed to combine them. Because we analyzed the data separately for each one of those measures, we'd be essentially explaining the same variance twice. So it just made sense to us to combine them in this case. So we're calling it implicit bias and not a specific form. And we do find that there are certain correlates for resident implicit bias that are interesting. And so we had higher implicit bias among internal medicine compared to family medicine residents, kind of interesting. They roll a little bit differently. We also find that, that years in the U.S. and being born in the U.S. correlate with implicit bias, such that people who come into the residency program from another country, they tend to be higher in implicit bias. We also find, interestingly, that if they had training in cultural competency in med school, they have lower implicit bias. Could be a good sign, right? There is a small correlation between explicit prejudice and implicit prejudice, but certainly they don't overlap. And some correlation between their motivation to control prejudice. The better they are at perspective taking or lower in their implicit prejudice, the more they subscribe to being colorblind, the higher their implicit prejudice or implicit bias. So, the million-dollar question. Does implicit bias on the resident's part predict patient satisfaction? We found that it does, but the relationship is not linear, it's curvilinear. And what you see here is that it's the ends of the continuum, the people that are high in implicit bias towards Hispanics, but also the residents high implicit bias towards whites are showing lower patient satisfaction. There's no correlation between implicit bias and sort of the midpoint of the scale. So it's sort of the extreme residents, like you might think. The surprising part is that if they have high implicit bias towards whites, we're also seeing lower patient satisfaction. So that's an interesting, unique finding. We'll come back to that. So now the question is, so what's determining that? What's going on during the interaction that's leading to these outcomes on the extremes? These are the variables that I showed in that big fancy model I said we were looking at, and I just want to start by pointing out that not many of them show any effect at all. So things like language style matching, demand withdrawal. We were also interested in the use of I, you, and we. No linear or curvilinear relationship there. So those variables sort of washed out. But what did correlate with patient satisfaction that's interesting, with implicit bias, is doctors high in implicit bias don't talk about the future with their patients. Kind of interesting. They don't do it two different ways. They don't use words related to the future, and they don't use words related to time. we've since drilled down into this data a little bit to figure out exactly what that means, and what it looks like is that what they don't do is when they get the patient in and sit them down, talk about what's going to happen in the next hour they're together. So they're not, sort of engaged enough with the patient to say, okay, here's what we're here to do today, right? It's just, what's your problem? And it kind of just feels to me like you'd think implicit bias would operate to say, let's just do this and get out of here. Just do this and leave, right? The other thing that we find is that question asking, the more questions they ask, affects satisfaction, or relates with bias. And so doctors with high implicit bias ask a lot of questions. I think maybe that's not so bad, until you look at the difference between the number of questions the patient asks and the doctor asks. And that's what this verbal dominance measure is. And so sure enough, it looks like it's being explained by, they're grilling the patient. They're asking many more questions of the patient than the patient is asking of the doctor. And then we find some things that we're just not 100% sure what to make of yet. Doctors with high implicit bias talk more about work, use work-related words. They use more relativity, sort of spatial relativity kinds of words. And, they use less and they use fewer prepositions. Shorter sentences, maybe? Interesting. So in trying to figure out whether these mediate any of the relationship we see between implicit bias and patient satisfaction, the answer is they don't. They're just correlates. What we found instead turned out to be a little bit more complicated than we thought, is that there's an interaction between implicit bias and the language doctors are using that predicts patient satisfaction. And so the degree to which they're using I interacts with implicit bias, auxiliary verbs, negations, complex words. This verbal dominance measure pops up again, and language style matching. Let me show you what these patterns look like, because it's hard to decipher what those interactions look like from that. Okay, so with respect to using the pronoun I, right, what we find is that for physicians with low and average bias, there's no relationship. But for doctors with high implicit bias, the use of I relates negatively to patient satisfaction. So the doctors using the pronoun I, when they have high implicit bias, that leads to lower satisfaction. Not true for doctors low in implicit bias. Same with interrogatives, and especially this relative interrogatives, the dominance. So doctors with lower or average implicit bias, no relationship. But for the doctors with high implicit bias, the more they dominate by asking questions, the lower the patient satisfaction. And then, this one's a little surprising. Language style matching, no relationship for doctors with low implicit bias, but for doctors with high implicit bias, greater language style matching relates to lower levels of patient satisfaction. So the more they're matching up the language, the worse that is for the patient. And maybe you have some ideas about what could be going on there. We're wondering if it's sort of this paternal kind of thing they're doing, where they're matching the language of the patient in a way that feels pejorative or, somehow paternal, and that's turning the patient off. We did find some things among low implicit bias physicians that are interesting as well. So auxiliary verb use among low bias physicians predicts patient satisfaction. Not so for high bias physicians. The use of negations, this is interesting. So, saying not tends to correlate with higher patient satisfaction, but only among low bias physicians. So there's some way they're saying that, right? And then finally, the use of complex words. This one's really interesting. Among low bias physicians, the more they use complex words, the higher the patient satisfaction. Right? So really giving you the stuff, right? I'm giving you the information. And that's not true for the high bias physicians. So what we're writing this paper about right now is that we found several things that are kind of unique in this literature. One is we found a quadratic relationship. The debate over whether the IIT predicts behavior or not, most of that is looking at it as a linear relationship, right? And I haven't seen anybody really talk about the possibility that maybe the relationship isn't linear. And we have evidence that that could really matter. And then physicians with high implicit bias, they endorse some beliefs that, are kind of bothersome, right? And probably not good for interacting with patients that are different from them. So, for example, they're more to subscribe to, or the higher their implicit bias, the more they believe in a colorblind ideology and just trying not to deal with race and ethnicity. And then there are verbal markers of the relationship between high implicit bias and patient satisfaction. The use of I, asking more questions, and that language style matching. And some interesting things for low bias physicians as well. Now, I want to make sure you got the clear picture on what we're finding. And in a way, it's not the clear picture that we were looking for at all. Because what it's showing is that when physicians with high implicit bias interact, and they do these things, something happens in the interaction that turns off the patient. And we don't know what that is right now, because it's an interaction pattern, not a mediation pattern. And so it's a little more complex, and we're now wrapping our head around how do we drill into what's happening when they're saying I that is leaving the patient. And maybe that there's some downstream language they're using that the I is precipitating that is then turning off the patient. The other possibility, and we can look at this a little bit, is there's something nonverbal going on, right? So when they say I, they start doing this. And maybe that's really actually what the effect is. And so we have to do video recordings to get at that. We can get at some of that through the audio recordings, but not completely. Okay. I will go through the rest of this quickly because I know we're running out of time. I think we're running out of time, right? Yeah. Okay. So the now question is, what can we do about this? And we've spent a lot of time over the last 8 years or so trying to create an approach where we're taking the social psychology of prejudice, stereotyping, and discrimination into the world of medicine and trying to make that work. Kind of like you might take a class from Dr. Gaffney. And everything you learn in that class, can we take that into the world of medicine and make that stick? And what we've been arguing in different papers and others have too is, yeah, that should be possible. I think, just to skip time, I won't talk about how difficult this can be, but it is important to know how not to suck at unconscious bias training. We've been working on that. Let me tell you what we've been doing. I mean, for me, to do this right, what we have to do is we have to tailor the material for medicine. Because what you find when you work with people in healthcare is they don't really care about our silly experiments, right? We can, hey, look at this effect. We don't care about that. All they care about is, will this make me a better doctor? Will this make me a better nurse, right? So I have to tailor it for that purpose. So, one of the things we find, maybe you've had some experience with this, is that the first thing you've got to do is make sure that people don't respond defensively to the idea that they could be biased. And that's a little bit of a challenge, right? So we do things to sort of lower the defenses early on. Like we give them things to read before they come to the training. We also do a little bit of self-affirmation with them. The other thing that you've got to do, again, they don't care about our experiments, but they do care about experiments that appear in medical journals. So you have to use clinically relevant research examples and scenarios to illustrate all the points you want to make. And then the other thing that I find is that you want to be able to think about bias reduction as a clinical skill. We get their attention when we pitch it that way, that these are clinical skills that you can learn that will make you better when it comes to communicating with patients. The abstract ideas of, that I'll show you in a moment, again, so what, right? But if that's a clinical skill, now I'm interested in learning it. And then finally, doctors learn by doing. And so they don't really respond very well to just reading material, although they get a lot that way, or to being lectured at. They respond really well to giving them the idea of the bias reduction strategy and then letting them practice it. And that's how they do a lot of their learning. So that was our goal, was to sort of create it this way. Okay, now real quick, I want to say a couple of theoretical things, and then I'll go to this. When you think about changing people's biases, what can you really accomplish, especially in like a hour-long class? And the answer is, well, maybe not much. But one thing you could try to do is change their implicit associations. You could try to get them to not believe that Hispanics are non-compliant. You could try to do that. When we first started, that's what we kind of wanted to do. We wanted to say, don't stereotype. It's not a good idea. And we had to reject that idea for reasons I'll talk about in a minute. The other thing you could do, though, is you could get them to activate control. You could get them to understand that, okay, when you come into contact with somebody who's different from you, that can serve as a cue for you to think differently about them. And they can learn that skill. And so we thought about doing that, and there's two ways to do it. One is you can tell them, don't stereotype. Don't activate the stereotype. Control the activation of the stereotype. And as soon as we started talking to them about this, we got a lot of pushback, and here's why. This is a great little essay by Sally Settel that was in the New York Times. She says, in practicing medicine, I am not colorblind. I always take note of my patient's race. So do many of my colleagues. We do it because certain diseases and treatment responses cluster by ethnicity. Recognizing these patterns can help us diagnose disease more efficiently and prescribe medications more effectively. When it comes to practicing medicine, stereotyping often works. And at first I was like, what? You're okay with stereotyping your patients? They don't say that. But what we came to understand is that the way that doctors are taught to work up a patient, they start with 55-year-old Hispanic male. And every scenario that they use to learn to diagnose disease starts that way. That's how they're trained. Why? It's because what they're taught to do is to use two things. Epidemiology, number one, which is the degree to which diseases cluster in certain groups. And that's a good place to start, right? So if I know I have a 55-year-old Hispanic male who's showing certain symptoms, that tells me something because of race, ethnicity, and age, right? Or gender, ethnicity, and age. And so they're taught to essentially, what we would call psychologists, stereotype their patients. But then what they're supposed to do is something different, right? They're supposed to go from that information to go now into individuating the patient. The other way they do it is they're taught cultural competence. That if you understand the relationship between culture and health, it helps you with patients who, for example, because of their religious beliefs, won't do certain things that you would tell someone else to do. If you know that, you won't waste time on that because they won't do it for that reason, right? I would call that stereotyping as well. But again, they're supposed to do that and then individuate the patient. So we found that we couldn't teach them to proactively not stereotype. What we found we had to do instead was teach them reactive control. Reactive control mechanisms. Control the use of the stereotype information once it's activated. Go ahead and think race, ethnicity, gender, right? But then think something else. In other words, we teach them to switch from stereotyping to individuation processes. Or as people are fond of saying, using stereotypes as a starting point, not an endpoint when diagnosing treatment, disease and illness. Okay. The last theoretical point I want to make is, who can we change? So maybe we have an idea about how to change, but who can we really affect change with? And certainly majority group, medical students, white students predominantly, right? They are the largest group in every medical school. We want to target them. But there's a really great question that comes up when you do this kind of work, and that is, what about minority group students? What about the Hispanic, African American, American Indian, the Asian American students, the students from Asia, Southeast Asia, East Asia that come to study in our medical schools? How are they going to respond to this message, right? And on the one hand, it's kind of a social justice message that everybody you would think would get. But there's some very interesting things that we have learned. On the one hand, some of the students that would fall in the category of minority medical students, Hispanic, African American, American Indian, they have grown up in this country being the target of the non-compliant stereotype their whole life, right? So they know this. They're treated this way with their physicians, their family members are treated this way. And one possibility is that, number one, they don't buy it, so they don't even have the association, right? And they may also just have control mechanisms already in place, and so we're in a way, telling them something that they've already sort of, grasped and done their whole life. So we may not expect to have much effect on them if there's any bias in the first place. But then you have the other students that we call in this research the non-targets of the compliance stereotype. And they're the Asian Americans, the Pacific Islanders, and then quite a few international students come to study medicine in our country. What about them? And there's a couple interesting things about them. One is that they're not stereotyped as non-compliant. They're actually stereotyped, in most cases, as confident. So compliant, they know what to do, but they're cold. And so they don't have the same experience as other minority students with sort of being the target of that stereotype in the same way. And then the international students are really interesting because some of them come from hierarchical cultures collectivist cultures that look at relationships as very hierarchical, and to tell them, hey, in a social justice world, everybody can be the same, right? Everybody gets the same treatment. You know, they come from countries where that's not true. And the idea that we're going to start breaking the hierarchies maybe isn't, going to fit very well with their cultural viewpoint. So we thought we may find high implicit bias among this set of minority students. And then the question is, how will they respond to our workshops? Will they respond the same way that we would expect majority group students to respond? Okay, I'll go through this quick. We did 2 studies. Didn't want to publish it until we had a chance to replicate it, and we just were able to do that in the fall. And so we got 97 medical students in the first year. You can see the breakdown there. We got 40 in the second run at this, and so we have a total of 78 majority group students, 42 non-target minority students, and 16 minority target students. That's a small group, but that's representative of most medical schools. And then what we do is we run them through 2 workshops, essentially. Before the first workshop, they complete the Hispanic white non-compliance IAT, and we get some measures of their resistance to how much they want to change, those theories of racial bias kinds of measures. 24 hours before the first workshop and the second workshop, they get lecture notes that I wrote about sort of the psychology of bias and implicit bias, and also some other things to read. And then we had a delay for 3 to 7 days before we measured their implicit bias again to see if we had reduced it. We had put in place those control mechanisms that we're trying to teach them. A couple of differences between the studies, you can ask me about that later. So the first workshop is really sort of an introduction to the psychology of implicit bias. It's a 50-minute lecture that I did. I have them do the thing on the flat that you did. And we talk about implicit bias. We show them examples from the medical literature where implicit bias is affecting patient care. So it's something that's relevant for them. And then in the second workshop, we created a number of active learning exercises where they actually practice the implicit bias reductions strategies as clinical skills. Okay, and I'll show you that just really again briefly. One of the things we really push is the idea that you have to be aware of not only implicit bias, but when it's likely to happen. And so we talk about, when you interact with patients, but also when you're looking at a chart, and maybe all you have in the chart is a person's name. Well, if you've studied enough psychology, you know that names can be sufficient to activate stereotypes, right? And so we point out that the patient doesn't even have to be there, and you could still activate an automatic stereotype and act on it with just a chart. And then we talk about these strategies. We take them through I had this incredible video made by one of my doctor colleagues. She was trying to teach how to interview a patient. And she made 3 videos, and in one of the videos, she does it purposely all wrong to illustrate how not to interview a patient. When I watched it, I said, Carol, she is doing all the nonverbal stuff that people do when they have high implicit bias. So we show that video, and we have the students go through and sort of code it and discuss what they see. It's interesting because they don't all see the same thing. We walk them through how to activate their chronic egalitarian goals, how to look for common identity information in a patient, what do you share in common, what groups might you have in common, what activities, interests. This one's probably the most effective and also the hardest to get them to understand, which is look for a way in which the patient is counter the stereotypes about their group. So if the stereotype is, a Hispanic patient might be non-compliant, we teach them how to ask questions that would elicit the degree to which that's true of this person. Because it may be the most compliant patient they've ever had. But if they don't go beyond looking at race and ethnicity, they may never know that. We take them through perspective taking, which they already kind of know anyway. And then we talk about planning and how important implementation intentions are. So you have to actually think about, okay, I have so-and-so patient, worried about this, I think I'm going to try to get common identity information today. How am I going to do that? So they actually make a plan before they do it. Okay, getting to the end. So, here are the results. This is the first measure of implicit bias that we took before the workshops. And what we find is significant interaction with gender. So the majority group medical students, the males are showing significantly higher implicit bias than the females. but they're both still showing a significant level of implicit bias because both those scores are different than 0. 0 is the, no preference for white or Hispanic. We don't see a difference between males and female minority non-targets, and both are showing significant implicit bias. And then we see for the minority target students, this difference is not significant, and neither of those scores are different from 0. This is the first study that I've seen in the medical literature that has shown a difference within minority group students on their level of implicit bias. It's a unique data set in that way. What did we find after? Well, we found that majority group students show a significant reduction. So now you're looking at pre-post workshop differences. And there's no effect for gender here. There's just an effect for change, and that's and by group. And it's the majority group students are showing a significant reduction. The minority non-targets are not showing a significant reduction in implicit bias. And the minority target students show a bias anyway. So a couple of things that's interesting here and important. One is we get a significant reduction, but that number is still above 0. So in my world of perfection, we're not there yet. We've reduced bias, but not to where I'd like to get it. And we're not having an effect on the minority non-targets, the Asian, international students. And if you're interested in that gender difference that I showed you on the pre-measure, there's just an effect for change. Both males and females among the majority group members show significant reduction. Maybe this is the best news of all. The female majority group students are at 0. They do significantly reduce down to 0. So maybe we're getting somewhere with somebody. So we have some evidence, I think, that a brief but active learning workshop can be effective for reducing implicit bias. It seems to work best for majority group female students. Less effective for the non-target minority students. We've been wrapping our head around why. Some of the cultural stuff, I think, could apply. The other thing that we realized, thinking back, is that all the examples that we show, all the studies that we show, it's always a white doctor interacting with a minority patient. And so they don't see them, they may not see themselves in the material we're using. And I think that's one of the ways we can make the material more culturally effective. One of the things that's kind of cool about this study for us is that there, again, in that literature of whether the IAT is any good and whether anything we know about bias reduction works, we actually have a kind of unique finding in that our effects occurred after a delay of 3 days, 3 to 7 days. And if you know Calvin Lai's work, you know that he showed that nothing worked after 24 hours. So we have a finding that's different. But of course, we're doing something very, very different than what those studies did. You can see how much we've tailored this for medicine. We've created these active learning exercises that are very involving. And the other thing that we do is we show the students multiple strategies. And what they tell me afterwards, they say, yeah, I didn't really like that common identity thing, but I'm going to use that counter-stereotypic thing. And somebody else will say, I didn't like that counter-stereotypic thing, but that common identity thing is pretty cool. So it's kind of like, here's a toolkit, pick the one that you like, but you have multiple things you can try, right? And of course, we want to replicate this, and we especially want to, we got to get back into what's happening with the non-target minority students and really work on that, certainly cross-cultural stuff. And then, the study we're running right now will address this last question. So what if you can change somebody's score on the IAT? What does that mean? It wouldn't matter to me personally if it didn't translate into something in the clinic that was better for the patient. So the study we're running now is these trainings that we're doing, half of the residents are getting them, the other half are getting a kind of a cultural competence thing as a control, and then we're going back into the clinic and reporting those interactions. So we're going to find out. That's what we're doing right now. So the last thing I'll tell you is that you don't get to do this kind of work without a lot of help. I have tremendous colleagues, certainly all my psychology colleagues, some of my former students, but lots of help from the College of Medicine. And I was talking to some folks earlier today. I find that the world of medicine really, really wants people like us to come over and talk to them because they get this problem and they can tell you stories about it. They know it's an issue, but they don't know what to do about it. And they see psychologists like social psychologists as potential help for that. So I'm really lucky to have this kind of support, not only from various people in our College of Medicine, but certainly the funding helps a lot too. So I'll say thank you.